Good evening, everyone, and welcome to NMA ITV for the National Medical Association Ophthalmology section. My name is Dr. Aaron Douglas Dotson. I'm one of the chief residents, or PGY4, at the University of Iowa, and I have here my other co-moderator, Dr. Daniel LaRoche. Would you just like to introduce yourself?
Hello, Dr. Daniel Roche, ophthalmologist, glaucoma specialist, New York City. Thank you, Aaron.
Thank you, Dr. LaRoche. And we have our very special guest here, who is Dr. Edgel, who will be talking a bit more today about cataracts. We're also going to be talking about a recent mission trip that he took. So questions that many of my patients have when I try to sign them up for cataract surgery, the first thing I ask them is, do you know what a cataract is? And believe it or not, I've gotten every other answer except the correct answer. So today we're going to answer questions. What are cataracts? Does everyone on the planet get cataracts? What is cataract surgery? What can we do about it? And what all goes into an ophthalmic mission trip within the National Medical Association? So without further ado, Dr. Edgel, could you just introduce yourself, talk a little bit more about your background in ophthalmology and your training, and then we'll dive on into your presentation.
Yes. Thank you very much, Dr. Dotson and Dr. LaRoche. It is my pleasure to present tonight on two things that I'm passionate about. So number one, thank you all my family, all of my friends that are watching, and all of my future friends. I want to take this time to start out by introducing myself. My name is Dr. Benjil Edghill. I'm a native of Bed-Stuy, Brooklyn, New York. I've actually moved quite a few times during my training in high school and college, but I ended up right on the same block I grew up on. So I'm a neighborhood boy who came back to serve his community. Right now, my main practice is in Staten Island, New York. I did my college at University of North Carolina, Chapel Hill, did my medical school at Duke, went up to New York to do my residency at Downstate, and went back down to do my glaucoma and anterior segment fellowship at Duke. I'm a former chair of the National Medical Association Eye Ophthalmology section, and we're gonna get started. So, bismillah. We always have to do a disclosure slide, but as you can see, I have no relevant disclosures. And I will be talking about Haiti and my passion for serving the people of Haiti, but I'm not Haitian. I always think it's important to start whenever we do anything about the NMA or via the NMA, which is the National Medical Association, the oldest organization for African-American physicians and people of color. To give you a little bit of the history, it was started in 1895. And the reason why it was started was not because we were trying to exclude ourselves from the main medical industry. Actually, we tried, or our ancestors tried to join the American Medical Association and was denied because of the color of our skin, not because of whether we were excellent, not because whether we had enough training, but simply because of the color of our skin. So in order to cross-pollinate, to gather, to share knowledge, we had to form our own organization, which became the National Medical Association. And it's not examples, hard evidence that we were practicing medicine well before anybody even entered the African continent besides the natives. In fact, I learned this from Dr. LaRoche that the first ophthalmology in written record was named Irie, and he practiced around 2400 BCE. In this right upper hand corner, you can see Marit Pata, which was the first female physician, and she was well respected. In fact, she was the physician to one of the queens of the time. You could even look at ancient creations down in that lower right-hand corner. That is not a real toe. That is actually a prosthetic toe made out of wood and leather, which was connected to the foot of somebody who lost their big toe, because at the time, most of the people wore slippers where you needed your big toe in order to keep your shoe and your footwear on. So they using their knowledge, were able to create their own prosthetic. And this was found on a mummy from the ancient Nile River Valley. And in the middle, you can see Eber's Papyrus, which is the oldest written record of medical knowledge. And it had information about surgical procedures, medical procedures, ways to treat common ailments, and even about eye procedures. So this is really our history. This isn't just medical history. This is our history. So as Aaron said, what is a cataract? Yes, I have to explain this multiple times a day. And it's not something that's so simple, because I've had patients say, is it a skim over the eye? Is it just something you peel off? Is it like an onion and you just remove layers? But actually, the cataract itself is the lens that you're born with. And this lens is quite amazing, because not only is it a way to focus light into the back of the eye, which is the retina. I'm dating myself and many of the people that are listening. One of the ways that we like to explain the eye is it's like a camera, with the retina, the back portion being the film where the light projects, and the film is converted into images by the brain via the optic nerve after it's turned into chemical and electrical signals. The lens and the cornea are the focusing mechanisms. They help to focus the light to one point as best as possible in order for us to see as well as we can. So why is the lens so special? Well, if you can see, there are little suspensory ligaments called zonules, and these zonules actually help the lens to change shape. So that is why when you're young, you can actually see things near, far, and everything in between. It's because your lens is actually changing shape to help change your focal point. Now, what happens over time is the eye starts to age, and the proteins in the lens start to oxidize, and it becomes harder for that lens to change shape. And as that lens becomes more dense, it's what we call a cataract. So when the lens starts to actually affect your vision, that means that you have to address this cataract. Sometimes you can address it simply with glasses, or modifying your lighting, or just moving things further away. I know a lot of people have, as they've gotten older, usually around age 40, they start to pull things further away from themselves so that they can read it. That is your attempt to get your vision to focus at a focal point that is comfortable. The problem is, because the lens, as it gets thicker and cloudier, doesn't change shape as well, it is more difficult for that lens to focus at different focal lengths. So what is our solution for that? Well, like I said, you can try glasses, but the cure is cataract surgery in most cases. Now, here's a close-up of our natural lens and those zonules that I was talking about. When we're born, in most situations, unless you're born with a congenital cataract, this lens is very clear and it's almost liquid. It can change shape very easily. And if you were to try to open up this thin layer, which covers the cataract, called the lens capsule, a lot of the lens protein would just simply leak out. This round circle here is the pupil, which is the circle that you see when you look in the mirror. That also is a mechanism that helps to filter out some of the light that comes in our eye. When it's bright, the pupil gets small to filter out too much light. And when it's dark, the pupil gets large, so we can have more light enter the eye so we can see better. Similar to how you would change your aperture on a camera, but this is one of those SLR cameras, one of the older cameras. So as I was saying, this lens can change shape, but as these different layers start to oxidize and the protein and lipids and carbohydrates start to change, it starts to change to a more cloudy or more opaque look. Now, how do cataracts affect patients? Well, in America, most of my patients are simply affected by having to either wear reading glasses, or they notice that when they're driving at night, there's a lot of glare with the oncoming headlights, which makes them uncomfortable, or they're just not seeing as clear as they used to. But when a cataract gets mature, which it can, this is what a patient might look like typically. So for those who don't understand Creole, including myself, I will attempt to translate a little bit. Basically, this is a woman that we saw in our medical mission in Haiti. And you could see she wasn't even aware that someone was trying to get her attention at first, because the cataracts are white, cloudy. They're so dense that she is not receiving much visual information at all. In fact, all she could really detect was some hand movement. But the more important point here is that the cataracts take away people's ability to live normally. This woman cannot ambulate or get around on her own. She needs someone to lead her from place to place. This woman cannot participate in daily activities like she could before her cataracts. The brain is dedicated, about a little over 50% of your brain is dedicated to vision and visual input. So you can imagine when you take that away, it really changes people's lives. So these are different types of cataracts. As I said before, the normal lens tends to be clear, and as things start to change over time, you see the cloudiness form. The mature cataract is the one that can be either dark yellow, blue, white. Even there's some cataracts we term as black cataracts, which look like dark rocks. The most common cataract is a nuclear cataract, which is when the center of the lens starts to become cloudy. But believe it or not, one of the most visually significant cataracts is the one that's called a posterior subcapsular, which is clouding of the back of the lens. Because this is closer to your focal point, it tends to really cause a lot of glare, and it makes people feel like they have a smudge in their vision all the time. So these cataracts, even though they may not be as dense, will be ones that patients tend to complain about earlier and need to be removed, because in most cases, the vision cannot be corrected with glasses. So this is a video. Some people will cringe a little bit, but this is how it would look for you to see cataract surgery from the outside, not through a microscope, not at high mag, but just so patients understand what it looks like, or just so the people listening will understand what it looks like to see a cataract surgery or to do a cataract surgery at the same time. Now, I'm going to play it. Hopefully, let's try to play this video. Okay, there we go. So as you can see, there is a small entry wound. All of these entry wounds are less than 3 millimeters long. That allows us to place small instruments into the eye. We open up the lens capsule and we have access to the cataract itself. We break the cataract up into smaller pieces that can be removed through this pink sleeve, which is actually a vacuum and a mini drill. It's what helps us to break up the lens into smaller pieces. And like I said, you can see pieces or fragments being removed through that same instrument. That second piece just helps you to direct those fragments into the vacuum. Now she's using a second set of instruments to help clean up any remaining material that's stuck to the lens capsule. We fill the bag up so that there's space for the new intraocular lens to be injected. Once it's injected, it's positioned into place and it sits right where your old lens sat. Now, I wanted to show this video because a lot of patients ask, do you take the whole eye out and then remove the cataract? Do you have to make a small incision or a large incision? In this case, which is called phacoemulsification, all the incisions are so small that you don't even require stitches. So let's go to the next one. There are multiple types of surgeries, but I'm just going to focus on the top 4 that you may encounter in America. Phacoemulsification, it uses the same instrument that I just showed you in a previous video to fragment the lens into smaller pieces and suck it up. Usually the incisions are small enough that they're self-sealing and they don't require any stitches. You may hear about laser surgery for cataracts. That's actually fairly new, but it's called femtosecond laser assisted cataract surgery. Fairly new, meaning within the past 15, 20 years. It's become more and more popular in the past 5 years. But what it actually does is you go to one machine where the laser helps to make the capsule opening, the wounds for the entry, and it breaks the lens up into smaller pieces. But the lens still remains in the eye. You actually have to go to a second instrument or a second setup where the lens is removed by the same phacoemulsification probe that was used in a previous surgery. Small incision manual cataract surgery is something that's mainly done in third world countries or in patients that have that dense lens that I showed you previously with the woman from Haiti. This is a technique that helps to remove the lens in 1 or 2 large fragments through a wound that's also self-sealing, but a much larger wound than what we would use for phaco. The construction of the wound is such that it is also self-sealing, but it may require a stitch or 2. Some people can do it with no stitches, but for the most part, it's reserved for lenses that are dense, that cannot be easily broken up into smaller pieces inside the eye. Extracapsular cataract surgery is surgery where you remove the entire lens, also in large pieces, but the wound for this one is large enough that you tend to require multiple sutures at the end. The healing time for that one is longer, and it's usually used when the other techniques cannot be done. Now, this picture of this lovely lady on the right is Patricia Bath, one of our pioneers, and she was the first of many. She was one of the first to get a patent that's as an African American. But why I picture her on this slide is because she invented the laser phaco probe, getting her patent in 1981. And this is the basis for most FLAC surgeries or femtolaser assisted cataract surgeries. So when we remove your cloudy lens, which we call the cataract, we try our best to put in a new clear lens that is a prescription that will help you see better. Now, I get a lot of questions from patients. Do I have to have a lens implanted? Well, in most cases, if you do not have a lens implanted, you will not see well. There are a couple of patients who may have an eye that's so long that the power is equal to what it would be with a lens or without a lens. But most cases, I would say 99% of cases, without a lens, they would require those very thick glasses that you may see people wear occasionally, especially in the past. The euphemism was Coke bottle glasses, but those glasses were an attempt to give you the same power that your natural lens gave you inside the eye. So the invention of the intraocular lens was really by somebody named Sir Harry Ridley in 1949. He was a British ophthalmologist, and he noticed that in World War II, pilots, even though they had eye injuries where a lot of the glass that covered their cockpit may enter their eye, the eye did not react to that type of lens or to that type of glass, which was PMMA. So he thought, well, if the eye allows this to be safely in the eye without causing an inflammatory response, maybe we can use this as a lens inside the eye. And so that's how the first intraocular lens was developed. It wasn't until much later that it was improved to the point where we can fold it and get it through a small incision. In the past, we would have to make a large incision and place the lens, and that required stitches and much longer healing time. So I want to show you our patient after the surgery, and you tell me the difference. As you can see, this is a totally different woman. She is much more animated. That is one thing I do notice is whenever, and this is particular to women, whenever a woman has cataract surgery, I tend to see her come in the next day with vibrant colors, with beautiful clothing. And I think it's because the difference between the pre-cataract state and their post-cataract state helps them just to see how beautiful they really are. And so you can see how she's smiling and how she's excited to see her daughter, and how her daughter even now knows that she no longer has to lead this woman from place to place. And this is just with one eye being done. You can still see the white cataract in the other eye. So why Haiti? Well, I'm lucky enough to have a partner, Dr. Anika Michael, who's involved with a medical team called AHDH. We are a medical mission team that goes to Haiti 2 to 3 times a year. And I'm going to show you just how beautiful Haiti is. All right. So I know before I went to Haiti, I had a very warped view of Haiti. All of my ideas of what Haiti looked like were based off of earthquake pictures and all of the poverty that I see on TV. But as you can just think about it. From the history of Haiti, it was the most profitable colony in the world because it's very lush and vegetation is abundant. There's a lot of resources in Haiti. But the more powerful message of Haiti is the Haitian Revolution, which began in 1791 and succeeded in 1804. And not only did Haiti defeat France, but they also defeated Great Britain and Spain during that time. Now, we directly benefited from Haiti's revolution because it led to Napoleon giving up on his idea of having a French empire in North America. This was directly the cause of the Louisiana Purchase, which more than doubled the American territory at the time. And it inspired other nations, including Northwest Brazil, Guyana, Venezuela, Ecuador, Panama, Mexico, and yes, America, for people of color to rise up against the notion that white supremacy was the way and the only way. So when I first started my medical missions in Haiti, I realized that there was just so much need there. There's plenty of people who want help, but the availability of medical care is very, very sparse. So we started the clinic slowly but surely. You can see we had our eye clinic on the roof of a building, but through fundraising and just complete commitment, we slowly were able to build our own eye clinic. And this is what our OR started out looking like. It was a closet where we had to stuff a couple of beds and some phaco machines. And slowly but surely, we were able to get world-class equipment. And now this is what our operating room looks like today, where we have Centurion. These machines are the same machines that I use in my OR in America, including this luminous microscope. So while we were there, we realized that we couldn't just have people find us because we were up in the mountains in a very safe town called La Vallée de Jacmel. Sometimes we actually had to go to the people. And as you can see, I was able to find Black Jesus, so I was very happy. Now, this is another young man that I want to show his videos. I'm understanding that you're not really getting a lot of the audio, so I'll just talk over these. But he was a young man who worked as a construction worker. And one day, while doing his normal job, he was electrocuted. Oh boy. Trying to start the video, and as you can see, he has this very intense scar going across his head. So the electricity from the wire was powerful enough that it caused all of the water in his lens and the protein in his lens to turn white and create a white cataract. This gentleman beside him is the guy that would help him get from place to place. And they literally rode on motorcycle about 3 to 4 hours to get to where we were. And he's only in his 30s. So this is us leading him to the OR. And as you can see, he really could not navigate without our help. This was a man whose life clearly was affected by his cataracts. So once we got him to the OR and led him to the bed, I'll just try to speed up a little quicker so we can have time for questions. I was able to do his surgery for him. And the beautiful thing about it is the results in some cases can be immediate. So as I sat him up after the surgery, I told him to keep his eye closed as I came around the bed. And this was during, right during the end of COVID. So we're still trying to be safe with our masks. And I tell him to open his eyes. And he immediately can see the difference. He's able to count. He's clapping like a baby celebrating. I mean, it's such a big difference in such a little amount of time. So this man's life is changed and his friend's life has changed. And that's why I keep having to go back to do more medical missions, just because of the impact that we have while we're there. So this is him immediately after the surgery. Even with the shield on, because the shield has holes in it, he's now able to navigate his way around beds, through the door, no help. He's a brand new man. And this is all the power of cataract surgery and the power of medical missions. So I'm gonna go straight to, this is the showing off of everything. He's able to read, this is the very next day. He's able to read all the way down to the bottom of the chart, which in this case is saying he has 20/30 vision. So how do we make this all happen? Well, we have to be very organized. Unfortunately, in recent years, we haven't been able to always have an anesthesiologist with us. So we give patients anesthesia by mouth, a sedative that helps them, and we control their blood pressure with blood pressure medication as well. We mark the eye so that we can keep everything organized, and each mark tells you what type of surgery the patient's having, whether they've been dilated already, whether they've gotten their anesthesia by mouth already, and then we bring them into the OR like you saw I did for that gentleman. We try to standardize all of our OR rooms where we have everything in a place where it's easily accessible, and we sterilize our own equipment right inside the same room. We have 3 OR beds working at the same time, and we try to group all the right eyes together and all the left eyes so that we don't have to change the room around much between surgeries. We try to standardize all the equipment we need. So even if we don't have a scrub nurse, we're able to do the surgery basically on our own. After we do the surgery, we have the patients all come in at once the next day, and we have somebody explain all the post-op instructions at once. This is in their native language, of course, and we create their post-op bags with all of the drops that they need. And usually they are accompanied by someone so that we make sure both the patient and their escort understands all the instructions. So, as I said, it takes a special type of person to do these medical missions. You have to be committed, because although some people just go once, most people go back, because there is such a profound sense of accomplishment and the fact that you're really impacting people's lives more than just helping them see the television better. You're returning them to being functional again. People have to be flexible, because sometimes the lights are going to go out, sometimes the electricity is not going to work, but you have to be able to work with what you have, and you have to have grit, because you're going to have hard days, you're going to have hard cases, but being able to see the big picture, knowing that all your efforts are to create a greater good, to create a situation where you are really helping people. Haiti is not the only place I've been. I've also been to Ghana, Africa on a medical mission, but I've committed myself to this region of Haiti for the past 7 years, because in my mind, I imagine that I could help get rid of all of the white cataracts within La Vallée de Jacmel at the very least. You need to fundraise, because these missions are not paid for by anybody but us. We try to get help from industry. We try to get help from people, and we hope that you will consider helping us as well. And you need somebody who's an amazing handyman. So this is the website for donating, ahdhaiti.org. As you can see, we've already done over 1,500 vision restoring surgeries. We've had 81 medical missions since 1986, and these numbers keep growing. If you can find it in your heart to donate, just know that every dollar you donate goes to helping your people, our people, the people of the world. At the end of the mission, we have to take inventory. We have to make sure that all this equipment is protected. And we have to make sure that we know exactly what we need next time, because we bring all of these things with us on a plane, or we have to transport it through a shipping company. So what is the future? Well, we've started telemedicine for some of the people who can't make it to La Vallée de Jacmel, where we're working. We finally were able to salvage a visual field machine. So we did our first test of peripheral vision that was automated last mission. And we have a SLT machine, which helps to treat glaucoma, especially in patients who have mild glaucoma. Now, our future goal, as you can see, although we try to keep our OR very clean, what we found out is that a lot of the bags that we pack up just get dumped off the side of the mountain. And their real cleanup crew are just some pigs that sort through and eat whatever they can. So we want to have enough money to buy an incinerator so that we can cleanly get rid of the waste. Now, I just thought it was fun to mention some of the amazing realizations that I came to while I was in Haiti. Number one, we do not use motorcycles to their fullest extent. The minimum that should be on any given motorcycle is 2, and the maximum I've seen is 5, including a little baby. You can do cataract surgery with just phone lights or flashlights, which is quite amazing. I'm not talking about safely, but you can fit over 50 people in a van of this size, including riding on the roof. And this is a picture that I saw in a neighborhood in Brooklyn, but I saw the same exact picture when I was in Port-au-Prince, Haiti as well. So the memory of George Floyd really is a worldwide phenomenon. He is somebody that has really changed the perception of what Black suffering is, especially at the hands of cops. So that's the end of my slideshow. I'm more than happy that you were able to listen to this, and I hope you have some questions. I'll be happy to answer any questions you might have.
Wow, Dr. Edgell, I just want to say thank you so much for the wonderful presentation and everything that you do, all the volunteers who went for this mission trip. For those who are listening, if you have any questions, you can please post them in the chat. We do ask for you to please be as respectful as you can. Just be mindful within the chat here. You know, cataract surgery.
Can you put the link in the chat in case people want to come on live?
Sure.
I'll give a chance for people to come on live, put the link in the chat, StreamYard link.
We'll get this piece over here. You know, one of the magical things about cataract surgery is, you know, I mean, as a young resident still getting started out with doing cataract surgery, it's just so amazing to see patients who have poor vision, and then afterwards their vision gets a lot better. But I think what's even more important for our older patients is that it helps out with mobilization. It can help out with independence. It can reduce your chances of falls. Patients who are demented, it could even help them out as well. But one question that some people may have is, you know, what is the recovery time after cataract surgery? Do they have to take eye drops afterwards? Do they have to be in the hospital after surgery, or can they go home the same day?
So in most cases, 99.9% of cases, people will go home the same day. In the past, it wasn't that way. You had to stay in the hospital overnight, maybe even multiple nights when you were doing the large incision cataract surgeries. But as I said, because these incisions are so small, they tend to seal on their own. A lot of patients don't even have to be patched that same night. I have my own patients in most cases start eye drops that night. They usually will use 3 different eye drops, one being an antibiotic, a steroid, and a non-steroidal anti-inflammatory. This will help them to heal fast from their cataract surgery and also prevent infection and inflammation. They're usually going to use those drops for about 3 to 4 weeks, but each week fewer drops. There are ways now where people inject medicine in the eye. That's called dropless cataract surgery, so they don't have to use drops post-op. There are some people who tend to have patients get little inserts that can be placed under the skin of the eye for steroid dispersion or other things like that. But one of the things that I did want to mention is that cataract surgery is refractive surgery. So whereas a lot of patients think that the only way to correct their vision is to do LASIK or PRK, one of the main ways to correct people's vision is through cataract surgery, and it tends to be a more long-lasting correction. Anybody that's over 40 who wants to get out of glasses, I steer them away from LASIK and PRK and start to enter the conversation about lens replacement. And that can be clear lens replacement or early cataract replacement. I know Dr. LaRoche has a firm belief that cataract also contributes to glaucoma. I completely agree with him 100%. I think in some patients who have glaucoma that seems to be refractory to treatment, the main culprit is the lens, which is growing and starting to narrow the drainage system. Sometimes it's causing liberation of pigment from the back of the iris to clog up your trabecular meshwork, which is the drain within the eye. And by removing the cataract, you can help to cure or help to alleviate some of the pressure spikes that the patient may be experiencing, which is causing damage to the optic nerve, otherwise known as glaucoma. Do you have anything to say about that, Dr. LaRoche?
Yes, I agree with you very much. We do have a couple of comments from the chat. Karina Carrington says, outstanding work. Thank you for sharing tonight, and I hope it inspires more people to support. And then we have a question from Stephen Turner. Is there an age when we should check on whether or not we need cataract surgery?
All right, so first I want to just say hello to Karina. She was able to accompany us on this past medical mission, and she did an excellent job. She's a medical student, and she was able to help work up patients, help in the OR, and help out in the clinic as well. So anyone interested in medical missions, definitely go to that website, adhdhaiti.org. There are more than a number of ways to ask questions on how to get involved in the next mission that we're going on. Also, for Stephen, I recommend patients get their eyes checked early. So really, once you're in your 20s, if you have any family history of glaucoma, or you have any history of injury, or you're wearing glasses, I think vision health starts early, even in your school age years. But as far as cataracts, most people will not start to develop cataracts until after 40. So most patients who come in around age 40, I dilate them. I look at their lens to see if it's clear. Even if it's just starting to become a little hazy, we'll grade that as trace cataract. Now, trace cataracts don't have to be addressed in most cases. It's just the early changes that the body is going through. but it should be followed over time to see if it progresses. Most ophthalmologists grade cataracts on a scale of 0 to 4, 0 being clear, 4 being very dense, and then after that, they might say white or mature cataract. I believe that there are other issues that may bring you to the ophthalmologist earlier. As I said, family history or just terrible vision from an early age. There are things that can be causing this that in some cases can be cured. So that's a long answer to a question that.
Yeah, I just want to follow up. I think that the work that you're doing in Haiti is great. Um, Unfortunately, in many parts of the world, in the Caribbean, many parts of Africa, Southeast Asia, India, there are tremendous shortage of healthcare providers, ophthalmologists, physicians, and there are a lot of people that are blind bilaterally from these cataracts that can be removed with a 5 or 10 minute procedure. So we definitely need to train more surgeons globally, particularly surgeons of color in these areas. Unfortunately, because of the history of slavery, colonialism, segregation, all these black areas around the planet have a shortage of eye doctors, and you see these types of problems. So it's good. I'm glad to see that Karina is a medical student and was involved with this. And so I encourage medical students to consider a career in ophthalmology and eye care. Uh, College students to study hard consider a career in ophthalmology. And for patients, it's important to get your eyes checked, particularly over the age of 40 for glasses, cataracts, check your eye pressure for glaucoma. And like Dr. Edgehill was saying, with the lens inside the eye, when it gets larger as it gets older. When it gets larger as you get older, it compresses the drainage angle. And when you touch the eye has a normal pressure of around 15. When it gets up to about 18 or higher, that can damage the optic nerve and lead to glaucoma damage. Dr. Edgehill, just one more question from the chat as well. How long does the cataract surgery take? And what steps do we have to do in America to prepare for cataract surgery as well?
So I usually tell my patients that it's going to take less than a half an hour. Most cases will take around 15 minutes, but there are more difficult cases where it can take longer. Some of the types of surgeries that I mentioned, like the small incision manual cataract surgery or the extracapsular surgery, can take as long as an hour, or if you're really good at those type of surgeries, you can still do those in less than half an hour. But as far as preparation for surgery, if you're diabetic, I tend to have patients start with an anti-inflammatory drop about a week before surgery just to get the eye prepared. I have all of my patients clean their lids and lashes with baby shampoo 2 days before the surgery and a day before the surgery to get rid of any bacteria that's on the lashes, because a lot of the infections that come during eye surgery come from the lashes, believe it or not. But other than that, they don't have to do a whole lot. They usually get a medical clearance so that they can be cleared for anesthesia. And at this point, our technology is good enough that the anesthesia is mainly just to help the patient's nerves. We can do what's called topical cataract surgery just by using numbing drops and intraocular numbing medication. And the patient can do that without any anesthesia. Of course, any surgery that's done on you is major surgery. So I would not tell a patient that they don't need anesthesia. I will always give them the option to have a mild sedative to help them to feel more comfortable throughout the surgery. Do you practice in a similar way, Dr. LaRoche?
Well, I like the tip you said about washing the eyelashes with baby shampoo, keeping the eyelashes clean. And we just recently got an alert from our hospitals and ASCs that these new medications that they have for weight loss, Wegovy, Ozempic, Trulicity, they delay gastric emptying. And so normally they'll tell you not to eat anything in the morning of the day of the surgery so you have an empty stomach because you're laying down flat and you don't want to have any food reflux that could lead to aspiration while you're doing the surgery, even if it's a short period of time. But now these particular products and medications I just mentioned, they can delay gastric emptying for about a week, where from several days earlier, you can still have food content in your stomach. And so now we have to stop these things about 2 weeks earlier to try to get medical clearance. This is just brand new off the shelf that came out in the last couple of weeks. But other than that, I do the same things that we do for the most part to help prepare patients. It's just good that patients can understand that there is a process before their surgery to prepare to get the surgery done.
And many patients ask me, will they be awake during the surgery? And the answer is, in most cases, yes. At times during the surgery, even with the anesthesia, they may be arousable. And that helps the surgeon, believe it or not, by we need you to focus on the microscope light. So by having you just awake enough that you can follow instructions, it makes the surgery faster, easier, and more actually safer for you. So we try not to put you into such a deep state of sleep.
We got another question from the chat. What can go wrong at the time of cataract surgery, and how can anything that goes wrong be corrected?
Well, as I was explaining earlier in the presentation, there are very small suspensory ligaments called zonules that hold the lens capsule in place. These zonules can get damaged, and sometimes they're damaged prior to the surgery, either through an injury or to certain type of diseases that or conditions the patient's eye may have. Now, if that is weak, it makes it hard for us to, number one, remove the lens safely, and number two, to place a new lens in the eye that will be fixated into the right position. So it is important that you have a surgeon who has experience, who knows how to handle complex cases when it comes to these type of situations. In fact, some ophthalmologists will refer some of these more complex cases out to a surgeon who has more experience with these type of complications. This is really the ophthalmologist or the eye doctor doing you a favor. So, heed their advice. I would say ophthalmologists that I'm familiar with and that are my colleagues all have the patient's best interests at heart. And so we're going to do whatever is necessary to try to get you the best result possible.
Excellent.
Aaron, you have any other questions?
No other main questions that are coming to mind. I don't see any additional questions here in the chat. But what I can say here is thank you so much again, Dr. Edgel, just to kind of reel it back again for everyone watching here today. Everyone at some point in your lifetime, if we live to be old enough, you more than likely will develop cataracts. Not everyone has to have cataract surgery, usually until it starts to affect the vision. So Dr. Edgel will get cataracts. I will have cataracts at some point in my life. Same thing for Dr. LaRoche. Most commonly done outpatient surgical procedure on the entire planet. Very, very commonly done. But once again, I want to say thank you so much, Dr. Edgel, for sharing your mission trip, sharing your passion, and sharing also the opportunity for others to donate if they do so will. And thank you so much again, Dr. LaRoche, for serving as my co-moderator, contributing such great insight and wisdom just through over the years of your practice. Any final words from either of you two before we close it out?
Well, wear sunglasses, don't smoke, eat your vegetables and your fruits. These things all help to prevent cataract progression. And go see your eye doctor, especially your ophthalmologist, so that you can have an evaluation and we're here to make sure that your eyes stay healthy for the rest of your life.
Dr. Edshaw, I want to thank you very much for being our guest today and commend you on the outstanding work that you're doing. And just to reiterate, everyone, make sure, particularly if you're over the age of 40, get your eyes checked at least once a year. Get your parents, get your grandparents checked, because there's many things that we can do to help prevent blindness from cataracts, glaucoma, retinopathy, making sure people are seeing properly in that respect. So thank you very much, Dr. Edshaw, and thank you very much, Dr. Dotson.
Thank you so much for having me. My pleasure.
Wonderful.
Have a great night.
We will end off today's episode of NMA Eye TV. And if you want to learn about a different eye topic in the future, feel free to comment on either our YouTube or our Facebook page, and we will see what we can do for you in the future. Thank you so much once again to my co-moderator and to our special guests. Everyone have a wonderful, blessed evening and a great week.
Good night.